So I think we'll begin with our webinar on equity in access, tackling barriers to treatment and care. We'll just go through a few housekeeping rules before we start the webinar. So this will be recorded and it'll be uploaded to our webinar afterwards, and you'll get the link for that. And obviously people are putting their name in the chat, which is fantastic. We do have a Q&A feature as well. Zoom has recently hidden it, which is very unhelpful. So to go and find that, you need to click on the three buttons on the more, and that should hopefully bring up the Q&A button where you can ask the questions. We do ask that people do not take photos of the speakers, and if you are attending in a professional media or journalism capacity, please do say hello, and we would appreciate it if you didn't use any AI tools such as note takers during the session. Now, we've only got one more patient partnership week session to go after this. I can't believe this week has gone so quickly. So we have our final one this afternoon, and we're so grateful to all of our sponsors who have enabled us to make this week happen. And as you can see, those are our other webinars that we had during the week, and they will all be on our website. Some are already up, which is fantastic. That behind the scenes people are uploading those, so that do take a look afterwards and you can watch the whole series. Now we're going to do a very quick poll, and if one of my team members can bring that up. Now, what I'd like you to just answer is, what is the biggest barrier you face when trying to access care or be involved in decisions about your health? And click as many of those as you want. And whilst people are filling in the poll, I'd just like to say that when people registered for this event and all of our other webinars, we asked people what they'd like to hear from the sessions. And so the questions that we'll be asking the speakers are ones that you have inputted into. So hopefully everyone will have their question answered, maybe not specifically, but hopefully the themes that you've been asking will be answered by the hosts. So I can't actually see the results of the poll, so I can't actually tell you. Okay, thank you. So the poll has come up now, and I can tell you that 70% have said that the biggest barrier for them is the long waiting times, which I don't think will surprise anyone. And the second biggest is 43% of you said that you felt that your views weren't valued, which is quite concerning. And then the next largest is location or transport is one of the biggest barriers you face when accessing care. So I think those are really interesting to consider when we continue with the webinar today. So thank you again for joining this discussion on equity in access, tackling barriers to treatment and care. I'm Sarah Tilsed, Head of Partnerships and Involvement at the Patients Association, and I'm joined by some excellent speakers today. Firstly, we have Kirsten Spencer, who will be joining us from a patient perspective. Hello. We have Will Pett, Interim Director of Policy and External Affairs at Healthwatch England. And you might be able to see that this is not Giles Lomax from Spinal Muscular Atrophy UK. This is now Rachel Power, Chief Executive of the Patients Association. Unfortunately, at the very last moment, Giles had to pull out due to an injury, and Rachel very kindly stepped in at the last minute. So we wouldn't normally have two people from the Patients Association on, but we just thought we didn't want to put too much pressure on Kirsten and Will to have to answer everybody's questions. So thank you very much to Rachel at the very last minute of stepping in. So at the Patients Association, we believe that everyone should be able to access the right treatment at the right time, regardless of who they are or where they live. Yet for many patients, as we know, that's still not the reality. Too many people continue to face barriers to receiving timely and effective care. They may be caused by where someone lives or the conditions they have, their ethnicity, language, disability, or socio-economic circumstances. But they can also be built into the health system itself through complex pathways, inconsistent services, or delays in adopting new treatments and innovations. And the consequence of these barriers are significant, as we know. There's delayed diagnoses, unequal access to treatment, poorer health outcomes, and increased frustration for patients, also for healthcare professionals. And in one of our pieces of work on health equity, a patient told me that because they had to travel so far for an appointment, that they paid £150 to get to that appointment and had to toss a coin. Do they pay for the appointment or do they pay for the food? So today's discussion is about understanding why these inequalities exist, but also recognising that they shouldn't be inevitable. So we'll explore some access issues in terms of regional variation in treatment and innovation, who is most at risk of not being able to access care, and how patients can work with the system. So we hope to identify some practical changes that can make the health system more holistic and more consistent and easier for patients to navigate. So thank you for joining us today. I hope you leave with a shared commitment to ensuring that equitable access to treatment and care becomes expectation, not just the exception. So now I will pass over to each one of our panelists, who will just give a couple of minutes with some opening remarks. And I'm going to go over to Kirsten first.
Hi, thank you. Good morning, everyone, and welcome. And thank you for inviting me onto the Patients Association today. It's going to be a pleasure, I think, to be a part of today's discussion on inequity in access of treatment and care. And I think when we talk about improving cancer outcomes, we naturally focus on scientific breakthroughs and innovative medicines and advances in research. And these advances are transforming lives, and they do rightly deserve to be celebrated. But from a patient's perspective, a treatment only makes a difference if it can actually be accessed. So too often where someone lives, which hospital they attend, and their financial circumstances, along with their ethnicity or even their ability to navigate an increasingly complex healthcare system, can influence the care they receive. And that's why we're seeing variation in screening uptake across different communities, differences in access to genomic testing, which is so important, and clinical trials, which can be a real lifeline. There's unequal availability of specialist nurses and supportive services. And the reality is that two patients with the same diagnosis can still have very different experiences and ultimately very different outcomes. I mean, cancer patients need tools to help them participate in their care. All patients do, really. And they need to know what questions to ask and how to engage in decision making. So as a patient and an advocate, I've seen these inequalities firsthand. I've spoken to patients facing long waits for diagnostic scans, or travelling hundreds of miles to access specialist expertise, or struggling to access newer targeted therapies that are available elsewhere. Because even if NICE approves a treatment, there can still be delays that before you can actually get it routinely in practice. For people living with cancer, those delays aren't just administrative. I mean, they represent lost opportunities for us, really, increased anxiety, and sometimes, sadly, poorer outcomes, because time matters. And we also know that innovation is not enough. I mean, the UK certainly has outstanding research community, and it continues to develop world-leading treatments. We're doing so well here in that aspect. But our challenge is implementation. Workforce shortages, limited diagnostic capacity, variation in biomarker testing, and differences in local adoption, which means that we don't have equitable patient care. And approval of a drug does not automatically mean access for the patient. And that's why I think these conversations that we're going to have today are so important. We need to explore why these variations persist, really, and what we can do about them. whether it's improving earlier diagnosis, expanding access to genomic testing or clinical trials, investing in workforce, ensuring patient voices are embedded in decision making, which I think is really important. How are we supporting our patients? We need to be training them. Otherwise, sometimes there can be people that don't really want patients involved because they feel that they muddy the waters because they're not really aware. And why would they be if they haven't been given adequate training? But we need to look at practical steps we can take to reduce these inequities. And ultimately, I think success shouldn't be measured only by the treatments that we're developing, but by whether every eligible patient has a fair and timely opportunity to actually benefit from them, regardless of their postcode, their background, or their circumstances. So I'm very much looking forward to hearing the perspectives of all of you and what I hope was going to be a constructive discussion on not only the challenges, but on the solutions. That would be great. Thank you.
Excellent. That was a wonderful introduction. Thank you so much. And now I'm going to hand over to Will, please.
Hi, good morning, everyone. First question, can you hear me?
Yes.
Great, okay, just want to check my microphone's working. Yeah, hi everyone, and Kirsten, thanks so much for your opening remarks. I mean, I think that, Kirsten, you start from absolutely the right place in terms of access often being talked about in terms of pathways, innovation, treatments, system reform. But for patients that we hear from, it often comes down to three really basic questions. The first is, am I clear about the details of my appointment? The second is, can I get to my appointment? And the third is, can I afford the costs around my care? And really, kind of fundamentally, if the NHS isn't getting these basics right, then access is unequal by design, and the burden falls hardest on the people that are already facing the greatest barriers. So I just want to explore just each of those barriers in just a little bit more detail. So let's say you need care. The first challenge then is, can I understand the details of my appointment? Am I getting the communications that I need? And ultimately, kind of we hear that administration of care is such a consistent theme across the roughly kind of 10,000 pieces of feedback that we receive from patients each month. So we recently partnered with the King's Fund and National Voices, and we published a report after kind of conducting some national research that found that 2/3 of NHS patients and carers who have used services in the past year have experienced at least one administrative problem. Now, what does that mean? That can mean issues with appointment letters. So we found that about a quarter of people had received an appointment letter after the appointment had already happened. It might mean a lack of regular updates while waiting. Again, we found about a third of people hadn't been kept updated about how long they'd have to wait for their care or treatment. It means having to chase test results. It means being given incorrect information. We've got kind of one case study here from one person who told us that I can't speak with a real person at my GP practice because Emma, the AI, blocks me from getting through. I tried booking an appointment and the AI said that it had sent a link online to my phone, but I don't have internet access, so I couldn't book. Most concerningly, this is not just about a frustrating experience. We hear that, of those people that experienced an admin problem, 41% of them said they were less likely to seek care in future. So this is not just a minor inconvenience, it's actively putting people off seeking the care they need. And of course, the inequalities point is really important here. We saw that the biggest burden of admin problems fell on those that are least financially comfortable, people with long-term conditions, and those that are neurodiverse in particular. So that's just getting the details of your appointment. What about getting to your appointment? And I was interested in the poll at the beginning that transport actually featured relatively highly. An appointment's only accessible if you can get there safely, affordably, and on time. And we found that about 4% of people have avoided NHS appointments because of travel costs in particular. And that's why support that the NHS provides on patient transport is really key. And we know that those services support around 11 million patient journeys every year. But we've done work in the last couple of years at Healthwatch England that's kind of shown some of the barriers that keep coming up for patients in terms of trying to get the transport support that they need. So that can mean difficulty accessing help. Forms that people have to fill in are long, they're difficult, time consuming. Patient transport services can often be unreliable. One person told us they had to wait 13 hours for their patient transport to an eye hospital. And eligibility rules can feel unfair, people being turned down because technically they can walk a short distance to get in or out of their car, but they have real mobility issues that that mean that they don't get access to transport support they need, but find getting to appointments really tricky. So the patients that this affects most, of course, are particularly disabled people, older people, people in rural areas and on low incomes. And really transport is something that is often overlooked, but is such a key issue in terms of access. And then finally, the last thing I'll cover before we move on to Rachel is just cost of care. The NHS is free at the point of use, but accessing care is not always cost free. So we've shown that polling that kind of we did in 2024, 1 in 5 people have avoided going to the dentist because of the cost, and that's up from the previous year. And we see similar results, albeit on a slightly lesser scale for prescription costs. So again, cost barriers don't just delay care, they worsen health, particularly for those that are already at the lower end of the financial spectrum, and mean that people are really actively having to choose between things like heating their homes, buying the food they need, or getting access to the healthcare that they require. And really, in this day and age, we shouldn't be putting people in that financial position. So I'll stop there. Just in terms of across our evidence, a common pattern is that the system often assumes people have certain things: time, confidence, money, transport, internet access, English fluency, flexibility at work. A lot of people don't have these luxuries, and really looking ahead, the NHS needs to design services around the people who face the greatest barriers, not just those who have it easy. So yeah, looking forward to this discussion. And as Kirsten says, hopefully we'll get into some of the solutions as well. I'll stop there, Sarah. Thanks.
Thank you. And that's such a good point about the assumptions that are made about people. I think that's so true. And over to you, Rachel.
Thank you. And thank you, Will and Kirsten. You've probably taken a lot of what I was going to say, so I'm not going to be long, but that's good because I think we're all on the same page and there are some great points. I was sitting listening to both of you, and I was reflecting on what we hear through our helpline and through our focus groups and our survey work. And I think every day we hear from patients who are being bounced around the services, who've been told that it's just not available, treatment is just not available here, or who have to become experts in their own care, just to get taken seriously. And I think what we need in the system, and I think, Will, you were hitting on it, is that curiosity of what it's like to be a patient, what it's like to actually end up in the system. So we've a lot of conversations around patient choice and patient agency. But if you just can't even access the treatment that you need, then choice and agency are just not important. And I think when I look at the poll results, they make that point better than I possibly could do. Long wait times, feeling like your views aren't valued, location or transport barriers. They're the top issues that people on this panel, on this call, told us. And isn't it interesting that 2 out of 3 of them are not clinical? They're actually what's going around the system. They're about how the system treats patients while they're waiting for treatment and whether that treatment's actually reachable in the first place. And so in a way that tells me that that's not a resourcing problem. It's about that dignity. It's about the communication. It's about value. It's about humility. It's about curiosity, and whether patients are able to feel as true partners in their own care, or are they just simply names on a list to be treated. And we all know that we are much more than our disease and our condition. It's about what's important to us, what matters to us. So I think if we think about the inequalities question then, and both of you have touched on that, this compounds inequality, doesn't it? Because if you're already managing, multiple conditions, rare conditions, or English isn't your first language, or you live in a rural area, somebody put it in the chat, it takes 2 hours to get to your appointment, there's no bus to come home again. We've heard that before. We had somebody tell us it cost £187 to get to their specialist treatment. I thought it was a misprint in the report that somebody gave me to read, but it wasn't. And that person was saying, I'm making a choice between food and going to my treatment. So Will's transport comments are just so important. So I think each of those barriers that have come up in all your talks, they don't just add to the others, they multiply them. And then what we have is the people who are least equipped to navigate a complex system are often the one facing the most obstacles in achieving it. So I'm going to stop there. I think absolutely we're all gone beyond kind of naming the problem. We all recognize it, and all the speakers have confirmed it. So we need to look honestly now about what's working and what areas, and what could be scaled up. And I think Will and Kirsten, you said that the challenge is making it the norm rather than the exception. Thank you.
Brilliant. Thank you so much, all. So now I'm going to go and ask each one of you some questions, and I'm going to start with you, Kirsten. And I'd like to know from you, how do you think we can move from talking about treatment innovation to ensuring that patients can actually benefit from innovation?
Well, I think we need to stop measuring success at the point innovation is discovered for a start, or approved, or even recommended, and start measuring success at the point a patient actually receives the treatment. I mean, it is important to celebrate the milestones of new drugs, breakthroughs, exciting clinical trials, and regulatory approvals. But for patients, this isn't, the finish line, and there can be years of delay, variation, and barriers to access before those innovations become part of routine care. So patients really do only experience innovation when they're sitting in a clinic and the doctor offers them the medicine. So I think to close the gap, there's probably 3 things we need to focus on. The first one is implementation. So we actually need to nationally a consistent adoption of proven innovations. So patients should not face a postcode lottery because of the different regions. I also live not in a university hospital. I'm long way away from London. I live in a little provincial place, quite a long way from the hospital, no bus to the hospital. And it can be quite complicated getting there sometimes. And also different regions move at different speeds. They have different levels of capacity, and interestingly, they can interpret guidance differently. And the NHS needs to get as good as implementing innovation as it is in generating it. So that's the first point. The second point I would say is diagnostics and testing. So precision medicine only works where we're moving towards precision medicine all the time. It's the buzzword, but it only works if patients can actually access the tests to identify who's going to benefit from the medicine. So if we invest in the targeted therapies, we also need to invest in the genomic testing, the biomarker testing, the pathology services, and the workforce needed to deliver them. And within that, there's already a lot of variation. So different pathologists might come back with different results from the same tissue. So that is something else that we need to be aware of. And they are working to make this more equal in terms of, equitable in terms of what information we're being given. And, there's little value really of identifying a target if patients can't access the treatment linked to it. And this shouldn't be the domain, as I say, of the University in London hospitals. And the third, and I think this is probably one of the most important things, is patient partnership. So as a patient, we often identify, and we'll find a wealth of information from our patients here today, we often identify barriers long before they appear in any official reports or performance metrics. And we understand where pathways break down because we're living them on a daily basis. I mean, I can sit and I can promise you, I might need to get through to my hospital and there's not one person I can get through to. I cannot get through to a person. I can't make the GP appointment for AI as well. AI is used as a barrier to keep patients away from the GPs, but I can't even speak to anyone on hospital. Once I persuaded the door person, the person who takes the calls when you ring in, who just is the operator, I persuaded them to run into radiotherapy and get someone from radiotherapy to run to oncology to get me some test results that I needed, because I just couldn't get hold of anyone. And I get messages. I mean, people laugh sometimes. It's not very funny. You phone up to leave a message on a phone and it says, don't leave don't leave any, no one's here to take your call, and don't leave a message because the phone's not manned.
Yeah.
And you just, this is what's happening to me. So I can understand, how people are really suffering out there. And that's something, again, I've said we need to take to the hospital executive because I think we need to do better. Um, so, involving patients and advocates within this communication, I think, is really important because, the earlier we involve them, the more they can help ensure innovations are designed and implemented and delivered in ways that work in our real world. Ultimately, I think innovation and equity can't be separated. So, the breakthrough only fulfills the promise when we have a fair opportunity to access it. And we need to be able to do that regardless of where we live, our background, and our ability to navigate the system or pay. We need to become better basically become better at implementing our services. And I talk about that a little bit later on, but from a patient's perspective, as I say, a treatment that exists but cannot be reached is not yet a solution or any solution. To be honest, it's quite torturous to know that you should be helped, but you don't know how to get that help.
Yeah, no, thank you, Kirsten. And yeah, unfortunately, your experiences are what we hear so often, isn't it? And yeah, it's worrying that we're hearing this so much. So Will, I'm going to go to you next. And we know that as we've been speaking about, some groups, communities, backgrounds have a lower experience of care. So, for example, ethnic minority groups, those from lower socioeconomic backgrounds. So what do you think that we can do to improve people's access to services and reduce inequalities in access?
Yeah, thanks, Sarah. I mean, I'll talk through maybe a few potential areas where there may be some solutions on just making people's experience of access easier. And actually, Rachel kind of mentioned the first one, which is the importance of choice for people. And that's particularly important when people are at the point of just trying to get access to the care they need. I mean, we know, for example, that the most important issue to patients, and this comes through what we hear from patients, but also through what a lot of the think tanks have uncovered through national polling. The most important issue for patients is access to primary care. And for us, we generally believe there needs to be 3 really clear routes into all primary care services, and that's over the phone, online, and in person. And we need to make sure that all 3 of those options are available for patients across all primary care services. And we've started to make a bit of progress on this in relation to general practice. The 10-year plan commits to trying to end the 8 a.m. Scramble, partly through bolstering and improving online access. And that's now a core requirement for GPs in the new GP contract that the online access will be there in core hours. That's a step forward. But we still continue to hear from practices who are not offering all 3 of those options at any given time and funneling people, kind of, as Kirsten said, funneling people into kind of online or AI phone mechanisms that just don't work for a lot of people. So we need all 3 of those mechanisms, and particularly in regards to phone access, people need to be able to speak to a human being when they can't navigate an AI, and that's something that continually causes problems for people. On primary care, it's just worth saying that on dentistry, I still think we've got quite a long way to go. The Find a Dentist tool that's used online is woefully inadequate. It's not updated regularly. It doesn't give people anything like a real-time picture of where there is NHS dental availability in their area. And we also can't put conditionality on NHS access. So in regards to dentistry, again, we're particularly concerned of cases that we hear about where parents are only able to get NHS access to dentistry for their children on the basis that they sign up as a private adult. That's completely in breach of the contract, and we are concerned when we hear about those kind of conditions being put on NHS care. So that's choice. The second is charges. I mentioned in my opening remarks about the impact that particularly kind of dental charges are having on people. We've seen, like, not every year, but in many years over the last decade, above inflation increases in charges, whether that's dental charges, pharmacy charges. We'd really like to see a limit put on charges, certainly so that they can't rise by anything more than inflation at the very maximum, because we have seen an increasing burden financially being put on patients, particularly in dentistry, which it runs completely contrary to the prevention agenda, which is wanting to get people through the door earlier to get seen. And there is precedent for this. To be fair to this government, we have seen in the last kind of year freezers put on pharmacy charges. That's great. That's a really good step forward. We need to see the same for dental charges, and we need to see a limit being placed on all charges that they will rise by no more than inflation. And then finally, data. The NHS is often kind of praised for the richness of its data, and we've got a commitment in the NHS 10-year plan that the NHS will be the most transparent healthcare system in the world. That's great, but we've got quite a long way to go still on that, I think. Some progress has been made on transparency when it comes to health inequality. So, for example, we've now got a demographic breakdown for the elective waiting list, and that's very helpful and valuable in allowing us to understand who on the waiting list comes from which demographic groups, how do waiting times vary between demographic groups. But much of the data in the NHS isn't broken down in that way. A key example here is we've done quite a lot of work on complaints data. That's a key source of data across the country on what's not working for patients. Like, you go to complaints data to understand what the barriers are, why people are tearing their hair out trying to get access to services. But we don't have any kind of demographic breakdown for that national complaints data. So we don't know who is and who isn't complaining from across different demographic groups and about what. That data would be so valuable to understand the specific challenges for different demographic groups. So we have further to go on that. I should note that next week we have the GP patient survey data coming out. For me, that's a real benchmark for quality in terms of kind of how you can break down data in a really granular way, but also make it really accessible for people to use. The tool on the GP patient survey website allows you to do some really rich analysis, and I really see that as a benchmark. So there's more to go on the data side, and in particular in regards to transparency around where there might be hidden waiting lists emerging. So people might be familiar with the kind of increasing focus on advice and guidance in general practice. This is where patients are being asked to wait while a GP gets in touch with a consultant to decide whether or not that patient should be referred for specialist care or not. We need some transparency on how long patients are waiting for those kind of A&G requests to be resolved. We don't have the transparency. So again, I'd really stress that moving forwards, we need as much transparency on data as possible to understand the problem in the first place. I'll just conclude this by saying that ultimately, and let's be honest, long waits for services aren't going to come down anytime soon. It's a bit like kind of turning around a huge oil tanker when it comes to the elective waits. So the experience of waiting is key. Today, we've had the publication of the minimum standards of waiting for elective care. This is for the first time going to set out some criteria for how patients should wait. So what they should expect when it comes to things like regular updates, comparative information, waiting times in terms of referrals being confirmed. It's a really good step forward, but they're not perfect by any means, and we need to make sure they're implemented. So as much as we talk about access, we also need to be realistic about, in the meantime, while we're waiting for waiting times to come down significantly, let's make waiting as comfortable an experience as possible for patients.
Thank you, and such an important point on data. And Rachel, I'm now going to go to you and ask you, so we know that access to care can sometimes be seen as a postcode lottery, which we've been speaking about today. And as we've said, it can be shaped by, I don't know, region, rurality, deprivation, local commissioning decisions, and as we said, digital access as well. So do you have any examples of where this plays out in practice? So thinking about maybe specialist services, waiting times, treatment eligibility, or perhaps workforce shortages. And what changes do you think, whether, I don't know, this in service design or funding, transport, digital support, could help perhaps close these gaps for people living in these underserved areas?
Yeah, I do, and I think Kirsten, in a way, hit the nail on the head. It's around partnership with patients, and that patient partnership, and Will, I think the waiting times, the minimum standards for waiting experience waiting times, it's really good, but we need to make sure the patients are the ones that own it, which we have been very clear about, and that they're aware of them. But I think the thing it connects directly to something that the poll just saw, is about patients' views, feeling that their views weren't valued. Because I think postcode lottery isn't just about where services physically exist. It's about whether patients is treated as partners in decisions about their care and what they can access. And or whether it's the system just tells them what's available in that area and where. And that's not good enough. And all the way through the chat now at the moment is the conversation about, so I think Will is completely right, that transparency on data, the experience of waiting, but communication, because all the way through the chat at the moment, people are saying, I can't get through. I can't find the right number, or I have to ring 5 different numbers. So I think if you take specialist care and think about postcode lottery, if you think about the genetic testing, cancer surgery, rare diseases, they do tend to sit in major city hospitals, don't they? And if you live rurally, it's not just a logistics problem. It's often a communication failure problem too, because I think quite often is that patients aren't asked what would actually work for you, about travel, about caring responsibilities, about what they can actually realistically manage, and what can the system put in place to support them with that. So somebody's put in the chat, and I've heard this before, people don't know they can claim back travel costs. Sometimes you can only claim them back retrospectively. Well, actually, if you can't afford to get your appointment because your postcode lottery doesn't have it in the right area, that's not helpful. And it also puts the patient at a huge disadvantage. So I think the same issue around kind of communication with patients is true around local commissioning. And we hear this within the helpline quite a bit. Within our organisation, is the same treatment can be funded in one area and declined in the next area. And patients are frequently the last to understand why, but also what can they do? What can they do to challenge that decision? And that's often support that the helpline are trying to help. So it's patients once again being excluded by the conversation, not giving the power, the choice, the agency to be able to argue their case and to make sure that they can get the treatment that they need. And I think that's where I go back to Kirsten's point, which is where partnership actually offers part of the solution. So areas that do it well, do it in partnership with patients. And I think we have to acknowledge right now the NHS modernisation bill and the loss of Healthwatch and local health watches, because the role that they take in making sure and looking at commissioned services in their local area, and how they involve patients directly in service design and shaping out patients' clinics, in flagging where digital-only models might be failing certain communities before they become entrenched. So somebody in the chat asked, will neighbourhood health help with some of this? And it will help with some of it. But that's if we don't have a huge focus on buildings, and we can get a culture and a system that's working together with local charities, with the VCSE, with the system, health and social care working together. And I think that could be a solution for a lot of it. But I think what we have to do is to make sure that where you live does not disadvantage you in the way that you can receive the care that you need.
Brilliant. Thank you. And I feel, Kirsten, I'm going to come to you next. I feel like so much has been covered that let's see if you can add any extra to this. But I'm just thinking, as a patient yourself, is there anything or what do you think is the biggest barrier that out of all of these things to equitable access that perhaps people just don't talk about enough?
Okay, I think one of the biggest barriers that often gets overlooked is patient understanding. It's kind of a health literacy, because we tend to focus on, whether a treatment exists or whether it has been approved, but not so much on whether people actually understand what's happening to them or what options are available. Do they even understand the options? I mean, how can they become an equal partner in the decision makers when they just don't understand what's happening? You know, and there's all sorts of complications, especially within cancer, within that. So, for example, there's sequencing issues. So when you decide to take a drug earlier on, that could potentially stop you from being able to access it with another one later in your treatment line because they don't let you revisit drugs. And sometimes the drugs are evolving, the rules are evolving. Does your oncologist know that? They might or might not. Depends how up they are with the most recent research and news. I mean, I'll quote her, she won't mind me doing this, it's my mum. But I remember my mum going through a cancer diagnosis with my dad, said the greatest barrier of all, of everything, was her complete lack of knowledge and understanding. You suddenly go from you're living your normal life to histology and treatment decisions and which pathways, and you're like, what? And when you're in shock as well, you can't really take it all in, and you don't know what they're talking about, and you don't even know what questions to ask. So she considers herself lucky that she had a Macmillan nurse who took her away and explained some of the issues and the terminology to her. But without that, the experience would have been even more overwhelming, I think. And this highlights how important it is to recognise that information alone is not enough. Patients and their families need information delivered in a way they can really understand and at a time when they're able to process it. These are two different things. And that's where patient advocates and specialist nurses and even initiatives like I'm trying to set one up locally of appointment angels, I call them, and where people really go into someone else's appointment to help them understand and navigate what's going on within the room at the time when they're there. So, you know, it's important that they have someone to interpret information. This can make a huge difference to their care. I think there is another problem as well, and that's one we don't talk about enough. It would be implementation. So about, I think, 8 and 10 years ago, retrospectively, the Nuffield Trust and the King's Trust argued that implementation capacity was the NHS's biggest barrier to equitable access. Or one of the biggest barriers, I think. And the NHS, I think, has become much better at supporting innovation. But recent reports from the Nuffield Trust and the NHS Innovation Accelerator continue to show that the biggest challenge is moving from successful pilots to consistent implementation of things at scale. So too often whether patients benefit will still depend on where they live or which clinician they see. And I think we can see this within the chat today. And I want to thank all the people for the time that are putting their comments into the chat because it really matters to us. And all I can say is, you know, it's good that we've got getting our heads together here. Because, you know, a treatment may be nationally approved, but if local services haven't developed it and you can't get there, or trained clinicians haven't embedded it into their practice, you know, patients might not receive it. And that's why two patients with the same condition can still have very, very different experiences depending on where they're treated. So clinician awareness and referral pathways are really important in the implementation strategy. And they need to be continuously reviewed and updated because things are changing all the time rather than treated as static. I mean, I can tell you, in cancer, very little is static. And even the most promising innovation won't improve outcomes if healthcare professionals aren't aware of it, are unsure of which patients are eligible, or they don't have clear, efficient referral processes. I mean, you know, we've got to embed our treatments into our routine practice, and also the supporting services around health issues can really, really ruin people's lives because they can't get the support, the physiotherapy, other things that really help them to live their lives. And we've got to realise these people are very valuable to society, and when they're just left down and they're not supported well, you know, they just can't live the productive lives that they should do and support their families and communities how they want to. So I think that's what I would say there.
Well,
And I just
was,
want patients to get it. I want them to be
yeah.
able to access it. You know,
No,
I
I
don't want
was
it to be about
smiling
who they
away
know.
because, yeah, I wholeheartedly agreed with everything you're saying. As someone put in the chat, people are suddenly professional care coordinators overnight, and that is
Like
so true.
CEO.
People are told so much information when they're panicked. They're being told something big, and then they're meant to go away and just remember that all. And as you say, but then the information regularly needs to be updated. So I couldn't agree more. So thank you so much for that. So it might have looked weird when I was smiling at all the bad things you were saying, but I was like, no, I agree. So now I'm going to go to Will, please, and I'm going to talk about we've got the government's plans of the 3 shifts, and considering the shift of analog to digital, do you think this could improve access to services, or does it risk alienating those already experiencing digital exclusion?
Yeah, thanks, Sarah. I want to talk about something quickly that Kirsten just raised that is about the analog to digital shift as well. But just a kind of a reminder, hearing some of Kirsten's remarks, that healthcare needs to be a human to human industry. It needs to be a human to human interaction when people are receiving healthcare. And I particularly think that's important when people are either receiving very complex information that they are struggling to understand, or when they are receiving incredibly difficult information. And it just makes me think of like one particularly heartbreaking case that we heard from one woman who had a gynecological issue, and she received her test results by text, which also told her that she would be unable to have children. And I just think that for somebody to receive news like that over text is just shocking and really awful. And I slightly worry about, the continued focus on moving to digital. If these are the kind of messages that people are going to be receiving off the back of test results, then I think we need to really carefully think about the direction of travel. But in answer to your question, yes, I do think that the digital shift could significantly improve access to services if it's done in the right way. I spent a lot of my opening remarks talking about some of the transport issues that people face, and that's obviously a particular issue for people in rural communities. So being able to access more services through your phone online will be a massive help for those people. It will kind of be an equalizing factor, enabling better access for people that would otherwise struggle to get to physical locations. I also think on the digital shift, it's what young people are increasingly expecting. Young people who are able to access all sorts of other services in their life at the touch of a tablet or a phone, expect NHS services to be accessible likewise through their phone. And I worry that private organizations at the moment are often doing that a lot better than the NHS is. So we, we're involved in the 10-year plan and one of the working groups, and we, really pressed for the NHS app to become much better, to become much more accessible for people, and to be able to allow people to do a much greater range of things. And we are starting to move in that direction. We're also moving to NHS Online Trust. The NHS Online Trust may be familiar to some of you. Essentially, it's a mechanism that will allow virtual specialist care for patients through the NHS app and through video consultations. There are huge opportunities here, and I was really pleased that Healthwatch locally and nationally were consulted on this because it was constituted a setup of a new trust. And generally the consensus across local Healthwatch, I know there's some local Healthwatch on this call, generally the consensus was there's significant potential, but there are real risks. And what we particularly wanted to land with the department is the risk of digital services essentially bypassing physical services. So if you are lucky enough to be able to be digitally literate, you have the NHS app, you can navigate it, you will essentially end up getting quicker care than somebody who has to wait for physical services on the waiting list. Now, we really want to make sure that that isn't happening, that whatever means of care people choose, whether that's online, whether that's over the phone, whether that's in person, that people are getting the same standard of care. And I also, maybe we'll kind of close by saying that there's a potentially long-term risk, I think, around digital services, which is I worry about in the long run getting towards what I'd kind of consider to be this kind of online marketplace for healthcare, that GP appointments become like booking an Uber or finding a takeaway online. And I worry about what that means for continuity of care. There's so much evidence in support of when you see the same person over a sustained period of time, there's huge health benefits, and it also has, huge reductions in terms of, hospital admissions, mortality. And I slightly worry that as we move to increasing digital access, how we try and maintain relational continuity is going to be a real challenge. I think that needs to be a conversation that we have much more in the health space. And yeah, ultimately, final point, choice. It's about choice. As I mentioned, people shouldn't be penalised for wanting in-person communication and care. I think that is a risk, is that we kind of favour the people that are digitally literate. I'll stop there, Sarah.
Thank you, Will. And Rachel, we often talk about innovation in healthcare, but why do you think it could take so long for new treatments and technologies to reach patients in practice?
Didn't really answer to this question, and it's because we're not working in partnership with patients. And so I think that's one reason. I think the second reason, it came up a while ago, it's kind of coming up in the chat as well, is that often frontline staff are receiving so much information about what's out there, and how does that get implemented into reality at local grounds. So I think part of it is structural, because approval is only the first step, and that comes after all the procurement, staff training, local commissioning. And quite often patients aren't involved in those conversations, and industry, when they're developing these, often will work with patient groups, but maybe could work an awful lot more in partnership with patient groups, and especially those groups where their voices aren't traditionally heard in healthcare systems. And we talked about this on Monday when we had the NHS Race Observatory on one of our webinars. The health system is also extremely and understandably cautious. But I think, again, if they worked with patients and we had a different conversation around risk, that would be beneficial for innovation to be addressed quicker. I think also workforce shortages can be an issue. I also think that retraining time for frontline staff on new treatments can also be an issue. And a lot of it is around that funding. And this is where the postcode lottery comes in again, because some areas have the funding to implement quicker. Other areas are waiting for someone else to implement it because they want to see, will it work, first of all? And that goes down to the risk. But I think the most important thing is that patients aren't routinely involved as part of that adaptation conversation. And I think, Will, that goes back to your point around choice. And your point, Kirsten, it's not just about information and what's going into the chat as well. It's about genuinely handing the power to patients so they understand what's there and what's available for them in their treatment. And that is about living your life to the full, and living beyond. And we hear that in our surveys as well. So I think I'm going to stop there because we're running out of time.
We are, and I can't believe that it's gone so quickly. And I'm looking at the time and I'm thinking, I think we've got time for one more quick question. And there's one come up, and I'm going to put this to Kirsten. We've talked about because of lack of communication and because of transport, etc., waiting times. People are waiting much longer for their appointments and treatment than they should be. So as a patient yourself, do you think what could be done to ensure that patients are waiting well while they're waiting for their treatment? And are there any barriers to waiting well?
Well, I think, again, it's about, that would probably be about communication to patients. So whilst you're waiting for your treatment, it would be nice, for example, if you were sent, you're, unfortunately, we can't see you until this date, but don't worry, until this date, this is what's happening, because what happens with people get diagnosed and then they're in a panic. And they're like, oh my God, what's happening? And there's just this stony silence. And then they start Googling and they start going, and then they can get very wound up. Hopefully they'll find some reputable charities to trust, and go there for some help and support. But, I think it is, again, about communication. And we do need, the other thing I think is a very important point to make as well, is that having worked for a long time within advocacy, we need to train our patients. because sometimes pharma is actually slightly cautious about involving patients because, again, they're in a situation where they're involving people that they feel don't really understand the situation. And how can they be expected to, because they've not been given any training? You wouldn't, so in the way that, so they understand the kind of constrictions that they're working under. And we were just talking about this yesterday with a strategy where I was saying some patients want to get involved in policy, but they need to know the guidelines around how they get it. For example, a patient going to a conference and going on and on about their own disease is not going to help patient advocacy. You need to leave your disease at the door, and you need to think about it in terms of what are patients struggling with, and and to begin to get those skills and to be able to negotiate even when things don't look very good for you and your patients, and without getting angry, and understanding that it's a negotiation and you have to act as a critical friend even when you don't, if you don't agree with someone. And I think we need to give also some patients the opportunity of actually being able to use the tools to help themselves. But ideally, my goal would be that we have the guidelines and we have the guidance and we have the equity and access so that patients don't have to do so much work themselves. Because to be honest, to be a patient advocacy, I'm supported by a lot of American charities to go to these international conferences. If you're just a normal person, you can't afford to go off to America to conferences. You can't go and go to these things in Westminster all the time. So it always makes me laugh when they go, we want a diverse patient voice. Well, you're not getting a diverse patient voice. I'm able to do it because I was sacked when I had metastatic breast cancer diagnosis. Another thing that happens to people who are very ill often. And so I have the time. But normal people working, their voice is just as valid. And they will be working, they can't afford to take maybe time off, but their voice is valid. So we also need to support patients to get to these places. If we want a diverse community, we need to get into those communities, which is what I've done actually when I consult pharma sometimes in America. And I say, right, we need to get into the communities. I've got some friends there, I'm going to send them in, and and get certain people that you want out so we can listen to them and build up trust. You have to build up trust. So there's a lot behind patient advocacy. We're often expected to bring a professional level and years of expertise to the table, and we're rarely compensated for it financially, and let our own families lose us as well. So that's something else I'd like to see, much better support for patients to become involved at this level so we can get a diversity of voice.
Brilliant, thank you. That's a great note to end on. And as my colleagues bring up our final slides, I'll just give a bit of a summary of what I've heard today. We've talked a lot about the need for transparency, improved communication. We really need to be considering choice, and just being aware of what we can do with all that wealth of data. We talked about how time really matters. If you're waiting for that appointment, if you're waiting for that letter. We talked about the issues with rural communities and having to travel so far, and the brilliant point that Kirsten made about patients needing to understand what is happening to them, and information alone is not enough. So how can we ensure that patients are getting support? So thank you very much, everyone, for attending today. A big thank you to all of our sponsors. As I've said, we wouldn't be able to put on this week of free webinars without their support. So we're very, very grateful to them. We're obviously very grateful to Kirsten, Will, and Rachel for speaking today, and especially all of you that have joined today and really contributed to the chat. I've been keeping an eye on it the whole time, and it's fantastic to see everyone engaging, asking questions, and speaking to one another. And as you can see, there's a bit of information on this slide about the Patients Association, so our membership, our helpline, our corporate membership. So if you would like to get involved with us more, please do contact us there. Everything that we've been doing this week will be up on our website this week or next week. So please do take a look. And thank you once again to everyone, and I hope you have a lovely day.